Thank you very much. Mr. Dogo Mohammed, you said yesterday evening that you have been in this national health insurance scheme in Nigeria. You've seen a lot of phases of thinking about insurance. So if you look at today, where do you feel the differences lies if you compare that to maybe 10 years ago? What are the big changes that are occurring in your view?
Well, thank you. I would like to join my colleagues to thank Royal Highness for the passion and, staying with us throughout is unprecedented. We thank you very much. That one answers the political component of this, because without the political, driver, to actually take the process, whatever we have been doing as technocrats, academicians, policymakers, etc., we just collect our handbags, go and put it there. What you really need is a political will to drive this process. And we are so lucky Her Royal Highness is here, and I hope at the end of the day, whatever project we have, she's going to take it up to the next level, to the United Nations. Because now what is in vogue is the universal health coverage. The reason why we are all grappling with this problem is quite a large proportion of our populations are excluded. And what we want them is to get them included. So as a special advocate on financial inclusion, one of the aspects is this health insurance thing. So personally, what I am taking home and what I have seen different over the years is I have seen awareness being created amongst all stakeholders. It started as, a small, element with very few academicians, technocrats grappling with the problem. Now it is going around. It's like a wind of change coming. And then the world all over now is looking at universal health coverage and through health insurance and maybe other products. But the emphasis is on some form of contribution. Because once it is that the people who are the end users will not contribute, sustainability is not guaranteed. Anywhere you find 100% subsidy, I don't think you can guarantee its sustainability. So we have to be thinking of those who can afford, and there are quite many. When you take my country like Nigeria, they say over 60% live below $1 a day. We are about 160 million. But then we have 110 mobile phone lines in the country. So what is the figure? Can poor people who are about 60% living below $1 a day afford mobile phones? So it's a question of priority. And then whatever we do, we have to understand that political environment creates the milieu that we can do things better. And I want us to think again outside the box. People think it's either top down or bottom up. I think it's both. None will wait for the other. Once you have the political will to drive the force, you will get the legal framework which will guarantee sustainability, because our political leadership comes and goes. And when you don't have the right environment, when the good environment left and you didn't have a legal framework to sustain it, then it's gone. Because another political group will come with a different agenda and may not be health insurance or universal health coverage. So once you have the political will, try to push the legal framework to establish so that even if people change, still the country has made it is a priority. And then the next thing, of course, which I understand is money, money, money. You must get money. But it's not just the money that you get that matters, but what of the human resource to drive the process? What of the infrastructure? What do you think about preventive measures that will reduce even people getting sick? What do you think of primary level of care, that they will get early treatment before it becomes a monster that will consume them? So there are so many elements which during the last 6 hours we have dissected. And now what I think we are looking at is a practical way of going about implementing these things. Because unless we can practically engage the population, it still remains an academic exercise. And that is what we have been grappling with over the years. And I would like, by the end of this particular sitting, we should be able to have a template whereby we could be able to engage, or you can help different countries to engage their population from this to this, from this to that, from this to that. And there is a lot of talking. I can't talk to my satisfaction, but all I can say is I feel satisfied. All the elements that one thought should be recognized have been recognized during this session. All it needs is to sanitize it and make it in a presentable form. Thank you.
Okay, well, thank you very much. I think this is also a nice sort of link to the rest of the audience, because this session is also about translating some of the findings of today, with a lot of observations by our ambassadors, to, well, the next stages. And we all know what some of the obstacles are. At least a lot of people in the room are struggling with them on a day-to-day basis. But the question is, how do you move further? And so I would like to open the floor to questions. The same procedure as this morning. You press the red button. And you...
A lot of this is about political will and that translating that into legal framework. We at the initiative, we work very closely with the International Association of Insurance Supervisors to really, and the standard setting bodies, to really influence the standard setting process. What I've learned through this process is that this doesn't just happen in a vacuum by supervisors. What this needs is us as a wider community to influence that process, and we can do that. These supervisors need that. They need data, research, and they also need to hear the voices of the local people. So things as simple as the videos that we saw today, those sort of things to influence the supervisors, which then go into the standard setting agenda, and then that pushes into the political will at the global level. So that's the sort of thing that we want to see happen. I think we as a community can make that happen.
So how to make things move further was your question. I'm going to put 5 priorities as takeaways. There are many more, but we won't remember many more. First, I think the knowledge gaps issue is a real one. It needs to be attacked not only using the best of well-honed research, but also in this very dynamic field, mining natural data flows, such as are available from cell phone technology and so on. Second, spreading the knowledge we already have. It's striking how many people in the world need to know more about what a few people need to know. Third, and supporting the first two, practitioners around the world need to connect with each other better. That needs to be facilitated. It's a point I made in the breakout, but making it here also in the larger session. There's enormous power in people who are working on these things day to day, whether they're in policy or technocrats or managers, to finding out and being in constant touch with each other. Fourth, there are more innovations out there than we know about in this room. So we need to capture them sooner and make them more widely known. And fifth, the point's been made that health people and finance people need to talk to each other. There are communities to bring together. There are also wider communities, and particularly ministries and ministers of finance. This feels like a field that is far too important to be left only to health people or finance people. It's political people, and it's people who control the purse. They're huge. If this is wrong, if this development is not gotten right, the macro fiscal implications will be disastrous. So ministers of finance have reason to care about getting it right. So those would be my 5. Knowledge gaps, spreading it, what we know, get the practitioners talking to each other more, find the new innovations, and bring in the other communities, especially the ministers of finance.
I've always been told by my economist friends that economics is a branch of psychology. And I wasn't seeing a lot of that today, and that's why I made my earlier comment. When we look at diffusion of innovation, you know, from agriculture or from wherever, we see that there are innovators, there are early adopters. We need to know more about the people who do come forward, and they will influence everyone else. So how they're reacting to it is going to be important. So I would like to see, again, some more qualitative research if we're not yet on that trajectory towards, tax-based universal health insurance for all?
We go beyond political will and say, what kind of insights do we need at the policy level to stimulate investment in healthcare and also stimulate the health insurance industry?
Okay, posing the question is answering them. So could you say what your answer to that question would be?
So the one is,
It's working.
yeah, the first obvious answer is doing more research at the policy level and trying to understand, you could talk about the situation in Ghana or Philippines or whatever, trying to, if those are good practices, try to document those practices. And I also still think that Africa also can learn something also from success stories in Europe. So one is documenting and the another one is engaging the African leaders to really understand that political context need to be favorable in order to induce the investments which is required in the healthcare industry.
As a practitioner, I would like to also make 5 short points. First, I think that it is clear from all the interventions today and from reality that one of the unresolved issues that are both a gap in knowledge and a gap in political will is the need to create a layering between small is beautiful and big is beautiful. Both have a contribution to make, not the same contribution. They cannot work in disconnect and we get success. No government is rich enough or efficient enough to layer a solution top-down. And in many circumstances where I work, we see that governments are viewed as part of the problem rather than part of the solution. So we need to harness both small is beautiful and big is beautiful. And that is not something that I've heard people tell me how can be done. So that also parks the debate whether CBHI is the solution or isn't the solution. Both are part of it. My second point is, it is absolutely eminently clear that insurance will drive health, but not the other way around. There are good doctors in all countries, but they're in the capital, in the rich areas, and those who have money get good healthcare even in the low-income countries. The driver for this will be insurance, and when the insurance makes sense, we will get it. When it doesn't make sense, this debate will be going nowhere. In order to do that, we come to my third point. One size fits all has been tried, has failed. Mass production has been tried and has failed. It's high time to do mass customization. It's not enough to say that one size does not fit all. How do we do mass customization is not just everybody's little trick. It's complicated. And one needs to do some things that are standardized to customize. My fourth point, systems have to be predictable. If they're not, they cannot be and should not be trusted, and they're not. Predictability is a huge issue, and it is composed of 2 kinds of things. It is composed of trust at the relational level, which is mainly local, and trust at the institutional level, which goes mainly towards governments. Those must be there if we want this system to work. And in order to have predictability, I come to my 5th point, which is that essentially, if the population is not educated about what is happening there, if we only train people for the industry, be it health, be it insurance, we're going to have the huge gap between those who ultimately have to pay a premium, decide to go to the right place, and essentially use a system. And today, nobody is doing insurance education as a mass activity. And it's as important as primary education. Nobody will pay for it unless it's rolled out. And if it's not rolled out, society will not have a universal coverage system, no matter how many declarations we have around it. These are my 5 points. Thank you.
Okay, thank you very much, David.